Hello, everyone, and welcome to Samaritans Purse International Health Forum. Delighted to be with you here today. Before we get started, as always, just a little reminder, would like you to utilize the chat box to your right and just encourage you to engage in the conversation, especially at the end as we dedicate time to Q&A. And as always, we're going to open this up in a word of prayer. So bow your heads, if you will. Dear Heavenly Father, we just thank you for this forum and this opportunity just to learn more about medicine and to utilize it as an opportunity to share the gospel. Thank you that Dr. Thielander has made time to be with us today, and I just pray that you speak through him. Lord, we again, thank you for this opportunity. Thank you for Samaritan's Purse, and we pray this in Christ's name. Amen. All right. Well, I am delighted to present to you today Dr. Keir Thielander, a personal friend and colleague. Dr. Thielander was born in Chicago, and he grew up in Indianapolis. He attended Indianapolis University School of Medicine, and then he went on to complete his general surgery residency at Fairview Hospital in Cleveland, Ohio. Dr. Thielander served as a general surgeon at Cleveland until he was called to train and disciple African doctors to become surgeons. Keir served as the program director of the Pan-African Academy of Christian Surgeons, otherwise known as PACS, the surgical residency program, and he served as the medical director at Bongolo Hospital, which is a 150-bed mission hospital in Gabon. He also worked as the West and Central Africa director for PACS, and he currently serves as the chief medical officer for PACS, overseeing 13 PACS training programs that are spread across the African continent. Really, I can just tell you personally that PACS is really just transforming Africa and providing new surgical capabilities across the continent. So it's an amazing ministry, and we're delighted to have Keir with us today as he presents a call to international surgical education. So without further ado, Keir, I'm going to turn it over to you.
Thanks, Lance. Thanks for that kind introduction. It's a pleasure to be with you all today from this live stream. Thanks to Samaritan's Purse for the opportunity to talk a bit about surgical education, which is my passion, but also discipleship and the call. So let's go ahead and just jump right in. If we can start out with our first slide there, call to international surgical education. We can go ahead onto that slide there. There we have, just to keep us all centered on what really life is about. And this is what it's all about. As Lance said, it's about the gospel and sharing the gospel. So surgical education is just a vehicle to do that. So a reminder here, Acts 1:8, you will receive power when the Holy Spirit has come upon you, and you shall be my witnesses, both in Jerusalem, Judea, and Samaria, and then finally, even to the remotest part of the earth. That's international, right? And Jesus came to them and said, all authority in heaven and on earth has been given to me. Therefore, go and make disciples of all nations, baptizing them in the name of the Father and the Son and of the Holy Spirit, and teaching them to obey everything I have commanded you. It's all nations. It's not just here locally, it's all nations. If we could have the next slide. And we have a responsibility here. We've been entrusted with the gospel, the good news, but we've also been given many other things in this country that most of us live in, or many of us here in the United States. And from everyone who has been given much, much will be demanded. From the one who has been entrusted with much, much more will be asked. And that's us. We've been given much and we've been entrusted with much. Those are two different things. Go ahead to the next slide. So today we'll talk about a couple of things. We'll start talking about surgical access. So access to surgery really around the world, but then dive into specifically to Africa. Talk about surgical training, what that looks like today here in the US, how that also looks in Africa, and how that can be a tool for sharing the gospel. And then we'll talk about the setting of training surgeons and what that looks like if you're going to go and be involved with surgical training and education and discipleship. How does that play out, and what are your opportunities? And then, of course, because I'm a part of PACS, one of our case studies will be to talk about PACS and what PACS is doing in terms of surgical education, evangelism, but also discipleship and training. So if we could have the next slide, we'll talk about surgical access. So this is a quote from a guy named Paul Farmer and Jim Kim. They said, surgery is the neglected stepchild of global health. And this was back in 2008. I'm pleased to tell you that it's no longer neglected, although we may still be the stepchild of global health. I don't believe it to be neglected. We could have the next slide. So out of that, from Farmer, we have this kind of academic global surgery definition. So it's a branch of medicine that's concerned with treatment of bodily injuries or disorders by incision or manipulations that includes cooperation and understanding. And here's the critical part: between nations, that involves education. That's what we're talking about today: research, development, and advocacy. If we can have the next slide. And remember, all of us who are believers were God's handiwork, created in Christ Jesus to do good works, which God prepared in advance for us to do. He has chosen human vessels for this work. There are a lot of ways God could do it, but he chose us to do it. If we could have the next slide. So to the surgical aspect component here, that I want you to understand very clearly something here, and that is that if you look at operating room density, or if you look at the number of people who have access to an operating room facility, keep in mind that word facility. That's what I want you to understand, is that even based on facility alone, there are 2 billion people on this earth that lack access to this basic need. Just a facility, just the building. There's 2 billion people out of how many in this world? 7.5 billion. 2 billion lack access. And if you look at the operating room density graphs there, the second from the left, you'll notice it says SSA average. That's sub-Saharan Africa. They average 1 operating room per 100,000 people. But in contrast to the average high income, you look on the right there, it's almost 20 operating rooms per 100,000 people. If we could have the next slide. So the Lancet Commission putting together that idea of lack of access to surgery, and also the understanding that surgery had been kind of the neglected stepchild of global public health. The Lancet Commission put together a group to investigate, what does global surgery look like? What is the reality on the ground of surgery in this world? And they wanted to categorize it in this way. They wanted to look at the access of surgery, so universal access to safe, affordable surgical and anesthesia care when needed. So safe, affordable, when needed would be timely, that it saves lives and prevents disability and promotes economic growth. And we would say, from a spiritual perspective, it also provides an opportunity to share the gospel when people are in the greatest need. They can recognize their need for spiritual things in addition to their physical needs. If we could have the next slide. So when they, in the summary of their whole study, which was 143 different countries and hundreds of thousands of people that were involved in this research, actually realized if you look at availability, safety, affordability, and timeliness, it's not 2 billion people who lack access, it's 5 billion people that lack access to surgical care. That's 5/7, almost 5/7 of the world. That's huge. That's a huge number of people that lack access to surgical care in this world. In the graph, in the picture you'll see there, in the depiction, you see Africa, the darker red is the areas that have the greatest need for surgeons or need for surgical care because it's lacking. And you'll see sub-Saharan Africa is one of the greatest places on this earth that needs surgical care. Next slide. So what does it look like to bridge that gap? So even just the gap between the 2 billion that we thought lacked access, which is based on facilities, and the 5 billion that we now know lack access, when you look at all factors, what are the factors that lead you from 2 to 5? What are the factors that bring you to 3 billion more people that lack access to surgery? A few of them, finances is one of them. Remoteness, so that's both remoteness from the facility, which is the 2 billion, but also remoteness from access to materials, and then trained personnel. So if you have a facility but you don't have a surgeon, the facility doesn't give you much access. So one way to look at this in terms of trained personnel is we can send them, and sometimes in the past we've done that, and people will train people locally, but they're really focused on their own aspect of what they're doing at that hospital. I'd like us to have a bigger vision that when we go and do this training, when we do education, that we can impact not just our little hospital where we've gone in that remote area usually, but we can impact a country, both health-wise, but also spiritually. In Jeremiah 29:7, we see, to seek the peace and prosperity of the city to which I have carried you into exile. And of course, mission work isn't necessarily exile, but it feels that way at times. And pray to the Lord for it, because if it prospers, that's the country that you're in. If it prospers, you too will prosper. To have a big vision of what it is that God's called you to and what it is you're doing when you go to do surgical education, not just focus on the people that you're with, but to see how it can influence a greater group of people, even a whole country. Next slide. This also highlights for us that there are more things to performing surgery than just an operating room. You need a surgeon, you need preoperative care, you need postoperative care, you need intraoperative care, anesthesia, nursing. And in those components, we recognize the lack of access for 5 billion people. So it's not just the 2 billion, and it's 5 billion. And with that 5 billion, is there something that we can do in terms of training or discipleship or both to impact this? If we can have the next slide. So the Lancet Commission also put together this list of 10 items, and you'll see I've highlighted just 3. The top one, a trained surgical provider, is needed. So this is their 10 needs for provision of safe surgical and anesthesia care. Obviously, you need a surgeon. That's number 1. Then they have a few others, and I want to jump down to numbers 8, 9, and 10. You need 24-hour surgical coverage. That's a novel concept in much of this world. Quality improvement processes, including audits of perioperative mortality, also something that is not routinely done throughout the world. And a risk assessment and operation planning for planned procedures. That's looking at contingencies. That's looking at what might go wrong. That's planning for things that you don't think will happen, but could happen. And that's a way of thinking that is different than is the case in many of these places that need surgical access. If we could have the next slide. So let's look at it in terms of, now we know there's a huge need. We know that there's a lack of surgeons, but if we don't know what our target is, what our goal is, that doesn't help us much. So what is the goal? Well, the World Health Organization has given us a goal that generally we would like to have 1 surgeon for about a population of 20,000 people. That's the desire. The Lancet Commission characterized this a little bit differently. They looked at it as SAO, that's surgical, anesthesia, and obstetric providers. So their suggestion or recommendation would be 20 to 40 of those surgical, anesthesia, and obstetric providers per 100,000 population. So just a little bit different way to slice the same concept. 1 surgeon for 20,000 or 20 to 40 SAO providers for 100,000 population. We get to the next slide. So we know the need is great. Let's dial down specifically to one area. And I want to look at the country of Burundi. Here you'll see a list of 10 countries. This is the COSEXA countries. And I'll elaborate on what COSEXA is a little later. The name means College of Surgeons of Eastern, Central, and Southern Africa. What that looks like in terms of these 10 countries, you have data there, and why they're doing training in those places, you see the need is huge. And to correlate this with the previous recommendation by the World Health Organization, look at the far right column. So that's, remember, the World Health Organization wants 1 surgeon per 20,000 people. And the far right column is the reality on the ground for those countries, these 10 countries that are part of COSEXA. And if you look at Burundi, it's not even 1/10, it's barely more than 1/100th of the needed amount of surgeons. It's 3/100ths the needed amount of surgeons. That's an enormous, you can't even fathom what those numbers mean. And if you look at the total, even going down to the bottom, we see that it's 0.1. So even for these 10 countries, the needs are not even close to being met. They're 1/10 of what the surgeon needs are. If we go to the next slide, we'll see that specifically in Burundi. And we see that they only have, at this time that this study was done, and this is courtesy of Professor Johnny, who's the current president of COSEXA, you see that this time they had 19 surgeons with a population of 10 million people. Now, most of us can imagine a city that we live in or a city that may have 1 million people, and that the equivalent would mean that that 1 million person population of that city has 2 surgeons. It's mind-boggling. You can't even fathom what that really means to people on the ground in real life. If we could have the next slide. So let's look at surgical training today. So obviously surgical access is limited. We looked at one specific country of Burundi and the need that they have, also in the setting of COSEXA. But what does surgical training look like? So if we could have the next slide. So this is the total number of surgeons in the Eastern, Central, and Southern Africa region. According to COSEXA, their estimate is there are approximately 2,400 surgeons. About 1,600 of them are practicing surgeons, and that means that 800 of them are still in training. There are either 450 that are in a university training program or 350 in a COSEXA training program. So keep that in mind, that we don't have populations for that exact to correlate that to, but I want you to look at the number of surgeons. The point here is looking at 450 university trainees compared to 350 COSEXA trainees. And COSEXA will be our example of a different paradigm. If we could have the next slide. So this is another way of looking at Burundi and looking at some other countries and their needs. Again, let's highlight Burundi. If we have the next slide, we can see how it dials in here specifically to Burundi. And they're looking at the assessment that they would need to have 165 surgeons trained in the next 10 years. So if you look in the middle there, just to the left of the red numbers, you see 165. So if you extrapolate that out over a 10-year period, that means that they would want to train 17 surgeons per year for the next 10 years. The sad part of all of this is currently Burundi is not training one surgeon. They have no surgical training program in Burundi. Why? It's a really good question, and it kind of breaks down the differences between the typical university or African-based, as a stereotype, as a generalization, African-based training approach compared to what we often look like here in the US or what COSEXA is trying to implement in the eastern region, Eastern, Central, and Southern Africa. And that'll be highlighted in this next slide, if we can have the next slide. And this is from COSEXA, their approach and their reason for their existence of COSEXA. So if you look at the traditional approach to surgical training, it's a master apprentice. You have one person training one person. It's a pretty inefficient use of your time as the trainer. It's really a hazard to patient safety because sometimes the master just turns it over to the apprentice, even if they may not be ready for that. There's very little quality checks or accreditation. And the things that you learn are what your master learned or your boss learned, and they taught you those same things. So there's not really an idea of ongoing continuing education. It's a system that I'll use a quote here from Einstein, which I think most of us would say that guy was pretty smart. And his conclusion here is to say, we cannot solve our problems with the same thinking we used when we created them. Let me repeat that for you. We cannot solve our problems with the same thinking we used when we created them. Now, I don't believe that anyone intentionally created the problem and lack of access to surgery in Africa, that they created that as an intentional thing. But the system that is in place here on the left side I just characterized for you is the system that has led to a problem of lack of access to surgery. And thinking that that same system will solve the problem that developed while the system was in practice is really not reasonable to think that way, and Einstein kind of helps us get that. We need something new, and COSEXA has come up with a new approach, or a different approach, at least for their environment. It's not so novel to us here in the United States, but it is different. It more reflects what we do. And their new approach, as you can see on the right side there, talks about high leverage through standardized, close to live materials, OR time that's focused on technique, skill, and patient safety, fewer education interference during an operation. You're focused on the patient. And the theme here is that it's clinical focused. It's a standardized approach with knowledge checking. It's a state-of-art procedures empowering local trainers to keep the best care that's possible in that local setting. So it's more appropriate to the setting that we need people to work in, where the access is so terrible. They're being trained in those settings so that they would be more equipped to be performing well in those settings. It's a different emphasis. If we could have the next slide. So I've characterized it this way to help those of us who may not be so familiar with these differences. If you look at a stereotypical or generalized African approach, it's a degreed program. At the end of it, you actually have a master's in surgery. It's a diploma program that a university must issue you a diploma on your way to becoming a professor. It's an educational pathway. It has significant educational and research components. You notice that I haven't mentioned the word clinical in any of this. It's almost an idea where the medical care that's provided, the clinical or surgical care that's provided, is just a necessary tool to obtain the professorial pathway. It is not the endpoint. It is not the goal. Clinical care is not specifically the goal. It's just something that's a part of. Now, contrast that with what we would have as our approach here in the US. We're very competency focused. We're a certificated program. So a certificate is giving not so much a diploma. When I finished my residency, I didn't get a diploma in general surgery that was a master's or a PhD. I already have an MD degree. When I got finished with my residency, I received a certificate of competence that I was able to be a general surgeon. And then I went through a board exam. That's our mindset here in the US. It's clinically focused. It's patient focused. It's focused on patient care. It's a different focus of the training. As a result, the results are also different. The outcomes in terms of training and the outcomes clinically are different because the whole paradigm is different in the way we approach the educational process. We could have the next slide. So what are some of the problems to implement? And this again is from COSEXA, thanks to Professor Johnny for providing this. It's to implement this scale up, to get to the point of needing or being able to graduate 17 surgeons per year in Burundi, where they're currently not training any surgeons. How do you get to that point? What do they need? Well, one is government and medical boards to realize and appreciate and assist in this scale up. It's recognized that it's, again, in distinction to the way we handle many things here in our country, in the US, where things are very private based and the motivations to do them tend to be different. Many things are go through the government system. And so they need some government pushing and government help and support to make this happen. Also to improve their surgeons' welfare, so more of their medical officers, MOs, are interested in training in surgery, an international surgical community. And this is what I want to highlight for us. They're recognizing they need an international surgical community to come alongside of them to assist with this training, whether that's visiting faculty, whether that's program support, whether that's support in terms of materials or examinations. As I'll share later, PACS has a significant involvement with COSEXA. We're a significant partner with them. And then other things like skill labs and online learning or e-learning programs. Those are things that we can make use of in today's environment that 20 years ago we didn't have available to us. We can head on to the next slide. So for me specifically, what was my call to go do surgery? Well, I kind of looked at it this way. Jesus says it's not the healthy who need a doctor, but the sick. He's come not to call the righteous, but sinners. For me, it was realizing that it's not the educated who need a teacher, but the uneducated, and those who don't have an opportunity to be educated. And if you look at places that lack surgical access, specifically sub-Saharan Africa, their lack of access to surgical education is just as dramatic as their lack of access to surgery. They go hand in hand. And it may my heart to go and share the gospel and also share the knowledge that God has given me and to equip people to use that knowledge for themselves. There's a recognition that it's not the educated who need a teacher, it's the uneducated. It's a place that they don't have the opportunity. If we could go to the next slide. So we've talked about surgical access, which we recognize in sub-Saharan Africa is abysmal. It's terrible. There's really no significant access. About surgical training, that there are new groups like COSEXA, PACS is also one of them that have a different paradigm for training that is now becoming greater part of the surgical training paradigm in sub-Saharan Africa. Specifically, the needs are there, the opportunity and the framework is growing to have an engagement, but how does that look on a practical level? What does it look like in those different settings for training surgeons? And I want to take this from both a spiritual and a secular perspective. And I also want to challenge each of us to think about this in a more broad way, that we're all partners together in surgical education and discipleship, even if the setting in which we do that is different. So let's look at the different settings, at least from my perspective, that we may have in terms of doing surgical education internationally. If we could have the next slide. So you see across the top, you can do this short term, you can do this long term. I think that's pretty self-evident. You can go for 2 weeks. World Medical Mission has some great opportunities for you to do that. Some of those are PAC sites, some of them are not PAC sites, but they have some opportunities to go and teach. CMDA also has some opportunities through things like Medical Education International to go and teach on a short-term basis. And those look differently as they break out in terms of who you're teaching, and that's on the left side. So you may go short-term or long-term, and then on the left side, you're teaching when you go, maybe in a secular environment. Even though you're a believer, it's really okay to teach in a secular environment. And I certainly hope that's true, because that means if it wasn't true, most of the Christians teaching in secular environments here in the US would not be doing the right thing. But it is true that that is very acceptable, and God calls us to do that. He's called us to do that here in the US, but also abroad. Christians teaching everyone, so meaning they are teaching people who are not believers, but also people who are believers. That's another paradigm. You can do that short or long term. And then also Christians teaching Christians. That's the model of PACS that I'll expand upon a bit later. That has both a short-term component, but also a long-term component. Could have the next slide. So long-term, boots on the ground. You may say, well, what is that about? I really want to just go and engage with people, and it's their problem, it's their responsibility to handle their own issues. I would challenge you on that. I think that we as a global society have a responsibility to engage people that have less than us, and to engage them in a way that is not just a one-off kind of spend a couple of weeks. That's important, it's valuable, and I'll get to that. But it's also important to be there long-term and do this thing together. We have a lot we can learn. I'll tell you, my 10 years in Africa, I learned an innumerable number of things. And I'm still discovering things that I learned there, ways that my 10 years impacted me. So boots on the ground is extremely important. And I would hope that I also left something behind for them, not just for myself. There's a responsibility to do that. We've laid that foundation that we've been given much. We have much to give. We have a responsibility to give it. And also you've heard that there's all, and you're hearing in this section here about the opportunity and the impact you can have when you do engage with international surgical education. If we could have the next slide. So what does that do when you go long term? It does facilitate the involvement of others. That's the short term aspect. It builds credibility for an institution. As they say, a prophet's not known in his own town, right? And if you're an expert, it means you're from more than 40 miles away. If you're from that town, you're not an expert. So it's some people from far and away, from abroad, bring a credibility to an institution. It's a reality, and we need to take advantage of that and use it to the benefit of everyone. It also builds relationships with nationals and locals that are doing the work on the ground, whether they're nationals that are from that country, or they may also be expatriates. In the African context, you may have other expatriates from a different country, so they're international, although their culture may be more similar to the one they're working in than, for example, mine was when I was in Gabon. We could have the next slide. So short-term engagement, it supports the local work. So have this in your mind. If you're thinking of engaging in an international education, surgical education way, remember that you're coming alongside to support work that is already existing. It's not about your own agenda. You shouldn't be having your thoughts, and sure you're collaborating and bringing something to the table that they want and that you recognize is also a need that you can provide. And you may be able to provide much more than you think you can in most of these environments. It can help encourage and energize the people who are the boots on the ground. As we all know, life is hard sometimes. And just having somebody to give you a break, give you a little bit of a vacation, to get you away from the 24/7 call that many of these people are doing. And if it's going to support someone who's boots on the ground that is an expat like yourself, it provides a link back home. I will tell you, it was a lifeline for us when we were in Gabon. My wife survived because of many visitors and a lot of that social interaction to just have a taste of home. That's not to say she didn't have a lot of friends who were Gabonese and those who were other nationalities as well from Africa. She did, and we have value those relationships and friendships. But it is something about having a link back home. If we could have the next slide. So in this paradigm, we looked at short-term, long-term in a volunteering basis, maybe in a secular side. Let's look at that now. Go ahead, next slide. So in a secular environment, it kind of looks like this, and I think Matthew 5:16 captures it. In the same way, let your light shine before others, that they may see your good deeds and glorify your Father in heaven. Now you'll see in the picture on the top left there, Aga Khan University, obviously not a Christian university, but there are Christians who work in those institutions throughout the world, and they have an impact. You see also in the bottom left there, Fairview Hospital. That's where I did my training. It's not a Christian hospital, but I was a Christian working in a secular environment, providing a light into a dark place, providing the gospel to people, sharing with patients, but also my colleagues and those fellow residents that I had there. So there's work to be done. Next slide. Remember, John 17:15 tells us, my prayer is not that you take them out of the world, not to be in our holy huddle. It's not to take them out of the world, but that you protect them from the evil one. And so often we neglect praying for those who are in these secular environments because we don't recognize the ministry that they're having as intentionally as our own ministry or as those who are working in a more dedicated Christian environment. But in some ways, they need our prayers more and they need our support more because they're on the front lines of that battle with not a lot of support. Next slide. So how about Christians teaching and not teaching non-Christians, but in a Christian environment? So this would be a situation where you may have a Christian hospital, but it's placed in a more Muslim context or a more secular environment that is not Christian, and they may employ non-Christians. They may also teach within their medical schools or their residencies non-Christians. Medical Education International, a group of from CMDA, also does this. They'll go and teach both in Christian context, which we'll talk about in a minute, but also in a non-Christian context. And they use that as a platform to share the gospel and principles when they talk about ethics and morality, things that are common to all cultures. They can talk about those and give a Christian perspective because they're using a context that is welcomed as a part of education, both surgically, medically, and otherwise. Mercy Ship also does this. They will train local physicians wherever they put that ship. They will bring in local physicians and they will train them. They will do some discipleship if they're believers. If they're not believers, they were happy to train them just the same and give them an exposure to the gospel in a Christian environment, but training everyone who comes to them. Next slide. And really, we can characterize it this way. To the weak, I became weak. This is Paul, obviously speaking. To the weak, I became weak. To win the weak, I have become all things to all people, so that by all possible means I might save some. We know it's the Holy Spirit that does the saving, but he uses us. We are the hands and feet of Christ. He uses us to do that and to be characterized by saying, well, I only do this or I only do that. Part of what I want you to understand and what I want you to hear in this idea of surgical education, discipleship internationally, and partnering it with the gospel is that every activity has value if it's what God has called you to, that you can do all things. You can become all things to all people so that you might save some. That's what it looks like when you live cross-culturally. You're becoming something that you've never been before. And that's okay. That's what God has asked of you. If we could have the next slide. So that's Christian teachers in a Christian environment. And that really can be looked at in Deuteronomy 6:7. Impress these things. These are the whole law had just been given. Impress them on your children. Talk about them when you sit at home, when you walk along the road, when you lie down, and when you get up. And that was our goal when I was at Bungalow Hospital, teaching, discipling, is that we talked about these things. We lived life together. We did it together. That was surgical training, that was discipleship, and that was also partnering with short-termers who were just as much a part of our team as those who were boots on the ground. It was really everyone together, working together, and demonstrating the love of Christ to one another. If we could have the next slide. And there are ways to engage to do this internationally. Here's a number of things that I've listed for you. Operation Giving Back, that's part of the American College of Surgeons. You have COSEXA, they have partnerships with visiting faculty that may or may not be at PAC sites, although a number of them are. The West African College of Surgeons also does surgical outreaches, PACs, which we'll talk about here in a minute. The G4 Alliance, Médecins Sans Frontières, or Doctors Without Borders, obviously Samaritan's Purse, World Medical Mission, doing an amazing job coordinating short-termers. Thank you for all that work. We benefited greatly at Bungalow Hospital from that, so I'll just take this opportunity to publicly call you out and thank you for that, your partnership, World Medical Mission and Samaritan's Purse, Medical Teams International, Medical Education International as well. So we can have the next slide. So just to bring it together and to kind of put it in a characterization of ways that you can go short-term with a group like Doctors Without Borders. You can be a believer and do that. Just because you're a believer and goes with Doctors Without Borders doesn't mean you did a bad thing. That's what God's called you to. You should do that. It's in a secular environment, but you have an opportunity. It can happen long-term in groups with COSEXA or WACS or even medical schools, all medical schools. Many of them, I shouldn't say all, many of them in sub-Saharan Africa would love to have a well-equipped, well-instructed professor to teach within their school. Whether they're a Christian school or not, you can be a believer and do that. You have groups like MEI and then Myeongsung Christian Medical Center in Addis. They have a medical school where they teach. It's a Christian environment, but they'll teach both Christians and non-Christians. And then, of course, PACs, and that's where I want to spend the rest of my time here as we spend the next 5 or 10 minutes talking about, maybe 15 minutes, talking about PACs and what PACs is and how we interface in a training environment. So that's going to be our case study that we're going to look at surgical international education and how you're called to do that. So next slide. So a reminder for all of us as we jump into this PACS side, the PACS, and I want you to hear me clearly, PACS is not the only way to do missions. It isn't. It is a way to do missions and surgical education. It's the way that God called me to be involved with, and I would be thrilled if he calls other people to do the same. But I recognize that he calls other people to be engaged with missions in ways that are not PACS. And that does not diminish the value of what they're doing. I think there's a watching world for us as believers, and that watching world would like to see this, that just as each of us has one body with many members. That's secular engagement, Christian teaching non-Christians and Christians teaching Christians. We have many members and do not all have the same function. So in Christ, though many, we form one body and each member belongs to all the others. And the question is, when you go, when I go, when we do this international surgical education, when we do that, are we validating each other's engagement and involvement? It's very important that we do that. It would be a shame that we can be identified as believers and be in different places, and the two people don't know that we're both believers, that they don't know that we have a connection, or even if they know we have one, it's contentious. That's not a good representation. So let's be unified. Next slide. Of course, that can look this way, and we all know this very well. In the essentials, unity. In the non-essentials, liberty. In all things, charity. And it's a new commandment I give to you, that you love one another. That's us as believers loving each other. As I have loved you, that you also love one another. By this, all will know that you are my disciples. I'll tell you, they're going to know we're his disciples anyway. It's just a matter of how we represent him. And I would rather it be with love for one another. So let's strive for that. And that is if you have love for one another. Next slide. So we talked about surgical access, surgical training, the settings for surgical training. We just finished that. And let's talk about PACS, a case study here. What does PACS do? Who are we? And how might you engage with PACS? It's an example of how things can, as God has ordained it for us and brought it to us, engage a surgical community and have an impact on a continent, really, through a small beginnings. So next slide. Just a reminder, Sub-Saharan Africa is lacking surgical access based on availability, safety, affordability, and timeliness. The global medical needs are enormous. Next slide. And billions of people don't yet know Jesus. And so this is, for those of us who are believers, we can come on back to the previous slide. We can realize that this yellow bubbles is the unreached peoples of the world. And they're not a whole lot different than the surgical access needs. These can be partnered together. Next slide. And this impact has a multiplication effect. I'll share about that through PACS. It also has a partnership in sharing life with people throughout our days, as well as mentorship, which is something that I think even the world is recognizing the value of mentorship, something that we've heard about for decades, if not millennia, within the Christian paradigm. Next slide. So PACS has partnerships, really a strong partnership with COSEXA. About a third of their trainees are also affiliated with PACS, and all of our trainees in PACS are affiliated with COSEXA. It's an accrediting body for us. We have a growing relationship with the West African College of Surgeons. We're thankful for that. That has been a growing good partnership. West Africa is a more challenging place, at least where our PACS sites are, and we would like to see that continue to grow in our partnership with WACS to impact West Africa as well. Next slide. So PACS, just to give some background and help you understand a bit who we are and what we do. It began in 1996, so the very late 1990s, in a place called Bongolo Hospital. This was not actually a slide from 96. We don't have one from 1996, any pictures from that time, but this was from the early 2000s. And you can see the three guys there at the bottom, Harrison, Kakalo, and Baltazar, are the three first PACS residents that graduated and that started their training. Next slide. It's really based on this foundation, and these things you have heard from me in the presence of many witnesses. Teach them to able men who are also able to teach others. You know, in our surgical world, we have a dictum where we say, see one, do one, teach one. And I think it's true. Often we have the misunderstanding that we came up with that idea. I think probably 2,000 years ago, a guy named Paul wrote this to Timothy. It sounds a lot like see one, do one, teach one to me. Let me read it again for you because I think it's important. And these things you have heard from me in the presence of many witnesses. Teach them to able men who are also able to teach others. Sounds like see one, do one, teach one. We get this. We understand that. It has a spiritual perspective as well. Next slide. So PACS vision, we envision African surgeons living the gospel and ministering to the sick. Next slide. With this mission, we exist to train and disciple African surgeons to glorify God and to provide excellent, compassionate care to the most in need. That's who we are. That's our vision. That's our mission. You'll notice that's not necessarily very limiting. It's pretty broad. PACS has a broad influence. God continues to give us a broad influence. Next slide. The way we do that, we're a rural-based training program. And I want to stop just on that rural side because that rural-based training program concept gels very well with the COSEXA vision. If you think back to those slides about COSEXA and what their new approach and new paradigm was, the surgical education paradigm, that's a more rural setting that you're going to implement those things. And that's the way we do it as well. And so PACS looks at the operating room as training. Pre and post-operative care is important. Clinical and academic study. It's annual exams. Additionally, we have Bible study and discipleship that happens. It's very hands-on with direct supervision. And that's somewhat different in distinction to what many of our university training programs in sub-Saharan Africa look like. There's not much hands-on work. There's not much direct supervision. COSEXA is looking to change that paradigm, and PACS would like to encourage them, as we are doing, and partner with them as we do similar things with very hands-on and direct supervision of surgical training. Next slide. We also have discipleship. It's a critical component of our program. We're a faith-based organization. We are a both and, we're not an either or. If one takes priority, it must be the discipleship, but a critical component is also the academic educational component surgically as well. Our discipleship program is a 5-year curriculum. It's kind of a basic pastoral training. Each year is a standalone year. Obviously, we have new residents every year. We don't want them to have their own curriculum throughout each year. So it's the same curriculum year by year that all the residents go through, and then it's a 5-year curriculum. So it repeats, and each resident would see all of the curriculum over the course of 5 years. Next. We have general surgery programs, and that is the foundation of who we are, but that is not all of who we are. We do have 9 general surgery programs. We have 1 pediatric surgery program at this point, 1 orthopedic program with another one starting in January, and possibly a 3rd starting in January. We do have head and neck surgery training as well as cardiothoracic surgery. That's our newest training program. That's a fellowship that would come after their general surgery training. PACS continues to expand. As you can see, some of these training programs, in particularly orthopedic and head and neck and cardiothoracic, have come on since 2014. We started in 1996. So these are more recent endeavors for PACS. And as I'll share about the future of PACS, you'll see that it's even expanding to even more subspecialties. Next slide. This is the location where we are right now, the locations, I should say. Most of our locations are sub-Saharan Africa, in Niger, Cameroon, Gabon. They're in West Africa. Ethiopia, Kenya, Tanzania, and Malawi in East Africa. And then in Northern Africa, we do have 1 site in Egypt. So we're primarily sub-Saharan, but we are also located in Egypt. Next slide. And this is who we are right now in terms of graduates and residents. You can see it's a kind of a busy slide with a big table there. But if you follow the green line, that's the number of programs we have. And the black line up and down there is where we are today. So to the right is projections. To the left is reality, what's already happened. We currently have 13 programs. We're looking at growing that probably to 15, maybe even 16, 17, or 18 in the coming years. Over the next probably 2 to 5 years, we may be closer to 20 programs as the Lord provides. We do have 79 graduates. Currently, we'll have 88 by the end of this year. And we have 76 residents in training. We'll have over in the mid-90s by January of 2019 in terms of trainees at that current time. So God continues to grow PACS, and we see the graduates growing and increasing, of course, but also the number of residents in training continues to grow. Next slide. So what is the effect? What is the impact? That was there's a need, there's a responsibility, there's an opportunity, and now there's an impact. And so here's an impact. You can see the Africa continent is taken out of that previous slide of the whole world, looking at surgical needs. And this is where PACS graduates are located. Now, we've colored them in yellow, and of course, 1 graduate has not changed the whole country. But you can see how it's beginning to change the landscape and the color throughout Africa as we train and disciple more Christian surgeons to impact that continent. Next slide. I want to give you 2 brief examples here, share with you about a guy named Jean-Claude Bataneni. He's the one you see on the left. This picture's from a few years ago when he had just arrived at a place called Nebabongo. Interestingly, both his parents and his in-laws worked at the hospital in Nebabongo, and that's where he grew up, as well as his wife, obviously. So they got married during Jean-Claude's residency in surgery. His wife, Christine, is also a physician. She was trained in Congo. Both of them did their medical school there. He came to his training at Bungalow Hospital. We spent 5 years together. And incidentally, my first 5 years in Gabon were with Jean-Claude. So we have a very strong connection and stay in touch to today. He is now working in a region where he is one of 2 trained surgeons for about 15 million people. He is not the only person doing surgery in that region. There are lots of people doing surgery on those 15 million people, but only 2 of them are officially trained in surgery to do it there. He is training others, and that is that 2 Timothy 2:2. He has been trained, and now he's passing along his training to other physicians. He's doing that in a very remote, isolated area with almost no surgical access. Jacques Ebele is on your right that you see on the screen there. This is also a picture from a few years ago. God has expanded both of their families. They would have a few more children in their pictures today. Jacques graduated from the Bungalow program as well. He went on to Cameroon, where he worked at our Mbingo site as the assistant program director for a couple of years. And most recently, some of you may know the instability in that region or have heard about what's going on in Cameroon. It's a place that you can be praying for. There's a lot of challenges. Well, that's led to a number of difficulties that ultimately God was calling Jacques to move to Malawi. So Jacques is now in Malawi at a hospital called Dayang Luke Hospital, where he is looking to start a PACS training program. He's currently the only surgeon, so he can't do that alone. He needs some help. But there are international surgical education opportunities in Malawi, as well as many other countries, to partner with a guy like Jacques, which if God had not called me to this role with the chief medical officer with PACS, I would probably be willing to follow Jacques wherever he went. But God has not asked me to follow Jacques at this point. But he would be a wonderful guy for anyone to partner with. So that's Jacques, who's now passing along, maybe even within the PACS paradigm soon, the training that he received in doing surgical training and discipleship. We could have the next slide. So for those of us who have received so much, and sometimes we are so caught up in the little minutia of what we have, these words from Leviticus, I think, can speak to us. They say, do not go over your vineyard a second time, or pick up the grapes that have fallen. Leave them for the poor and the alien. I am the Lord your God. I think those words still ring true for us today. It may be more than just not picking them up. Maybe it is picking them up, but sending those leftover grapes and the other things that have fallen, not our leftovers necessarily, but things that we can give to engage a surgical education internationally. We've received so much. We need to give back. Next slide. A couple of things to think about as I wrap up here. What has God given us as a society? That's as a group. What has he given us? Not as individuals, that's the next question, but what has he given us as a society? As, let's say, the United States of America, or maybe pick your city that you live in, or pick the state that you're in. What blessings has he given you? And if you're in the country where I'm currently presenting this from, in the United States, the blessings that we've received, you can't number them all. You cannot. You can't. And those that we have an excess of, you also cannot number. We have a lot that we've received. What has God given us as a surgical community? Whether that's the American College of Surgeons, whether that's your surgical group at your hospital, whether it's the group of surgeons in your city, or the group of surgeons that you went to residency with. What has he provided for your surgical community that you can give back? And then individually, what has God given you? Some thoughts for reflection. I know we're going to have some time for questions here for the last 10 minutes or so, but think about those things and reflect on them individually. I don't have those answers for you. God has them for you. So ask him, what are those things that he may be pushing and impressing upon your heart to give back? Next slide. So I want to characterize in closing in these 4 ways that the needs were evident. We saw that, surgical access, that we have a responsibility. We've been given so much, and God has asked us to give that back and to share with what we've received. We have an opportunity, and you saw that in the surgical training paradigms, a group like COSEXA in the secular realm that is doing international surgical education, 10 different countries that they're overseeing in East Africa and Central and Southern Africa, that there's an opportunity to engage with groups like COSEXA. There's opportunities to engage with groups like PACS. I would be happy to chat with you about PACS at length, as much as you want. It's the burden that God has given me and what I'm passionate about. And then we have an opportunity to have an impact. And the impact you may not see in this lifetime. It may be next lifetime, or you may see it even in a direct turnaround from a patient that you care for, or someone that you've trained that is now implementing the skills that you've given them. Next slide. But when you do this, I want you to also keep in mind that there's a balance. There's a balance of responding to the perceived needs that a culture or a place that you're going to engage with internationally, their perceived needs, and acting on your own convictions. And I'm not going to highlight one over the other. They are both important. God has a call for you individually when you go and do surgical education, but God also has a plan for the people that you're serving among and with. And their perceived needs are also important, and they need to be valued. Not always acted upon, but certainly valued and often acted upon. Next slide. So the need is evident. Yes, there's a call. We have a spiritual responsibility. The opportunities abound. There's no lack of opportunity. In sub-Saharan Africa, no lack. Even Northern Africa, there's no lack of opportunity. Where's God asking you to have an impact? I think for the last 10 minutes here, we have some time of interaction. Happy to answer questions, or I pretty much am certain I won't have all the answers to all your questions, but I know someone who does have those answers, and you know him too. So feel free to pose those questions. I think it's between Lance and I to interact on those questions. So thank you for the opportunity to Samaritans Purse. Thank you very much, World Medical Mission, for the opportunity to share about my passion of international surgical education, about discipleship, and to talk a bit about PACS and the call that God has given me over these last number of years.
Well, thank you, Keir. That was an excellent, comprehensive presentation with regard to academics and teaching internationally. And I'm just looking at our listening audience, Keir. There's a lot of people that are very involved in surgical management and teaching worldwide, and so I'm sure there will be many questions. But just to start off with, I just again appreciate. Really just wanted to highlight a few things you said. Number one, I love the fact that PACS really, couples discipleship with quality surgical training and education. And I think it's awesome to see a group like PACS leading the charge for sub-Saharan Africa. And it just gives us an incredible opportunity to provide this skill set. And again, to couple that with Christian discipleship. Really just developing strong, mature Christians who happen to be surgeons for the next generation. So that's incredible. And I thank you for what you are doing. So enough of my talking. Let me pose some questions to you. Let's see. Starting off, some post-residents, Jesh Thiessen says, have new PAC sites found that the addition of surgical residents augments the efficiency and care for patients? And then also, how do staff surgeons find the addition of residents in the extremely busy surgical services?
Those are great questions, Jesh. Thanks for posing them, Lance. Thanks for providing that question. Those are things that PACS has thought about quite frequently. When new PACS sites are open, does it augment efficiency and care for patients? Well, one thing, it adds more people. And as we know, one of the greatest needs is manpower in sub-Saharan Africa. So if you don't have enough people, you can't do certain things. But if you have more people, just by definition, you're going to accomplish more things. So having a mid-level at that point as a resident, someone who can be both interfacing with the nurses, but also interfacing with staff and learning, is a significant help to the efficiency and care of patients. Patients get better follow-up, and the follow-up is significantly improved. It's an educational opportunity for them in doing that follow-up. It really adds quite a bit. In terms of staff surgeons, finding the addition of residents in their busy surgical service, the first year or two are tough years. You have first and second year residents that don't know that much. Sometimes they think they know more than they actually do know. It's a dangerous place. We've all been there, but that can be a problem. But when you get to the third, fourth, and fifth years, so we're talking year 3, 4, and 5, the impact on both longevity and quality of life for the staff surgeons is undeniable. The residents now in an environment where you can entrust to them certain procedures that you know they are capable of doing. I'll take an example as an ectopic pregnancy. A fifth-year resident certainly can do that. In fact, I would propose that a fifth-year resident ought to do that without the staff in the room. But in this environment in the United States, you can't do that. But in our environment, where it's a very practical, what needs to be done, teaching environment, it's good for that resident to do that routine ectopic pregnancy case without the staff surgeon standing across the table telling them everything to do. They're capable of doing it, and you know that. And so it means that your night's sleep get longer when you're the staff surgeon. They also get more efficient because you get called down to the operating room when the patient's already ready. But that doesn't happen in the first year of the residency, or maybe not even the second. It's not till about year 3, 4, or 5, and certainly by year 5. But year 3, it begins. You start to have some hope. In year 4, you know it for sure. In year 5, you can't believe how great it is when you started a new surgical training program. That's really been kind of the process of things.
All right.
So yes, Jess, you should start training with PACS. Let me just put that plug in there. We want you to do it.
All right, we will encourage him to do that as well. Let's see, Keir, Richard Davis asked, what are your thoughts with regard to partnering with the U.S. academic surgical community and their current interest in global surgery?
Yeah, great question, Rich. And I think I'll go back to the paradigm that I gave about engagement as Christians, that there are many ways to engage the surgical community in making use of our academic colleagues in the United States where they want to plug in, but also where we can provide them a place to plug in, I think is important. Who's to say that that's not the opportunity that they may have to hear the gospel? It's an opportunity they may have. And we can provide that as the surgeons that we are. So I think it has to be measured. I think it has to be intentional. So I think the connection is important. We should be doing it, but I don't think we should do it in terms of they're going to meet a need we have, because when you start relying on that, then your vision of your hospital, if you're a Christian hospital, or the vision of your training, if it's because you've now chosen to use people who don't have the exact same interest as you, and you've chosen to use them in a way that meets a need that you have. Now, I know the needs are immense and it's hard to balance that, but if you can use them as an additional aspect to not necessarily meet a great need, but to come alongside and provide more value to something that you're already doing, then I think you're taking a pretty low risk and you have an opportunity to have them have an exposure to the gospel, but also engage in surgical education internationally, which they all want to do. The other reality is this type of engagement in a PACS training site is something that will be very familiar and comfortable for people from the United States who are training in these environments, because they're used to the Western paradigm of training. To go and try to engage in their way of understanding training in a university system, in the majority of university systems in Africa, would be very foreign to them. It's not impossible, but it's a much greater cultural gap to overcome than coming to a place that already has surgical training in either a COSEXA model or certainly a PACS model.
Great. Thank you, Keir. Thank you, Rich, for that question. The next question, I think you know this gentleman, Bruce Steffies. He says, God made it clear to some listening that they have a responsibility in the face of this great global need. If so, if you have the ability, what will be your response? So that's I don't know if that's a rhetorical question. It's certainly one that's pensive and makes us all think. So that's a great question.
Yeah, absolutely. Absolutely. And I'll just recognize that Bruce is my predecessor in this role. He, excuse me, led PACS as the CEO, executive director from 2006 to 2016, or until 2015. In 2015-16, he had this role as chief medical officer. And most of what you see within PACS has nothing to do with me. Has everything to do with God through the instrument of people like Bruce and even his predecessor, Dave Thompson, in starting PACS. So Bruce, thanks for posing that question. And as I would take it as a rhetorical question as well, yes, I'm sure the Lord is speaking to someone, and I would be happy to have a conversation with that person about where, as Bruce likes to say, God loves you and I have a wonderful plan for your life. So I'll steal Bruce's words. And although it's true God loves you, he also has a wonderful plan that may involve international surgical education with a group like PACS or COSEXA.
Awesome. Well, I know they don't want me to, but I will just call out David Thompson, Bruce Steffies, and Keir Thielander, just for their years and years of dedication and work through PACS. Very just incredible organization, and we appreciate so many, thousands of hours that you all have put in. And I know there's a lot of African physicians that are appreciated as well. And anyway, so thank you so much. I think that is all of our questions at this point. I did just want to throw out, this is a quick advertisement. Starting tomorrow in Asheville, North Carolina, will be a prescription for renewal. If you've never been there, it's just an incredible medical conference and opportunity to join Samaritans Purse and World Medical Mission. This year we'll have Johnny Erickson Tata and Jim Simbala will be our keynote speakers, but it's just an incredible opportunity for you to get away with your spouse and enjoy fellowship and learn what Samaritan's Purse is doing globally with international health. So I encourage you to join us in that conference. Let's see. Also, I just want to remind you that there is CME credit available with this session. The form and instructions are on your email that was sent to you. And you also will be receiving a follow-up email with this recording. If you're not on our mailing list, you can join the forum at health.samaritanspurse.org. Encourage you to do that. There's a whole archives of many, many incredible presentations, comprehensive presentations with regard to international health, and there is now CME attached to those recordings. Our next recording, webinar will be November 14th. Dr. Bryant Ward, he's a former post-resident that served at HBB Hospital in Togo, and that topic is to be determined. And I think that's it. So for all of us here at Samaritan's Purse International Health Forum, thank you for joining us. God bless.